TOLAC, used to be called VBAC. Now it's trial of labor after cesarean section. Welcome to Talking with Docs. We have a really interesting topic. I'm Dr. Brad Wiening.
I'm Dr. Paul Zalzal.
We have a guest.
I'm Sandy Andrighetti.
Dr. Andrighetti is an obstetrician gynecologist. He's going to talk to us about when mothers have vaginal births after having a previous C-section, which before used to be a no-go. People just didn't do this, not allowed. Had one, forever you're getting C-sections. But now that's really changed. So tell us about that.
The evolution of childbirth.
The evolution. So we have supported trial of labor after cesarean section as obstetricians, I guess my entire career, which is going on 28 years now. So,
wow. Yep.
But it's not without risk, and everything merits a conversation, risks and benefits.
Okay.
Yeah.
Let's talk about that. Why?
Just one sec. Before we talk about that, just interestingly, when I was in second year residency, we had to do our licensing exam. Mm-hmm. One of my oral questions during the licensing exam was discuss vaginal birth after cesarean section. I was an orthopedic surgery resident. I had to go in.
Oh, really?
Yeah, because for the generic licensing exam,
Yeah.
right?
Oh,
that's
yeah.
super.
My question was on VBAC.
How'd you
Wow.
do?
I got my license.
Yeah. There you go.
You're allowed to
Thanks
fail.
to all my OB trainers during residency.
Because you're allowed to fail one question?
That's not nice to say. I knew the answer. I knew you're allowed to have a trial with a low threshold. But
Let's see if there's any new information
I
from
suspect
that
there's
time.
a lot. That was over 25
From
years
last
ago.
week.
Okay, here we go.
That's why your high school football team's called the VBAC.
That's right. That's right. Okay.
So what was your question? Can't remember
Gone
now.
after that.
All right.
No, I was going to say, so what are the risks? Why is that a risky notion to try and have a vaginal delivery after you've had a previous C-section?
So it's a small risk, but can be a catastrophic risk. And the biggest one is really that you're laboring and the scar, not in the skin, but the scar in the uterus or the womb can separate during labor. It can actually separate before labor and very infrequently, but the biggest thing is during labor, it can separate. That's pretty rare. It's about 5 to 7 per 1,000 trials of labor.
Okay, so when you've had a cesarean section, you've had an incision through the skin and through the subcutaneous tissue and through the uterus.
Right.
To have the baby delivered through that incision.
Right.
Then after the baby's delivered, you suture that back down. And as we know in surgery, whenever we make an incision and close a wound, there's always a scar.
It's like patching a tire, I say.
Yeah.
Okay.
It's never the same tire.
Right.
And if you're going to be driving your Formula One, that tire may blow.
Right.
And that's labor.
And that labor's a big muscle, right? It's squeezing
Big
and pulling
muscle.
on that
That's
scar,
right.
and then if it's not strong enough,
That's
then
right.
it tears.
And labor's like Formula One. It's not like driving around to the corner store. It's going hard.
Yeah.
So when that happens, that can separate. And thankfully, it's very infrequent.
Okay. But that is probably the biggest concerning risk you're saying.
Absolutely. And that's a big risk because although it's catastrophic, we have a very short time to get that baby out.
How much
as
time?
quickly. So the guidelines are really to try and get that baby out before 10 to 15 minutes, which means that if you're going to have a trial of labor after cesarean section, you have to be in a facility that has in-house or available obstetricians and care providers.
Yeah.
So some smaller centers, for example, can't offer that service because they don't have the health resources for it.
So basically, you had a cesarean section. Fast forward, now you're having another child, and you want to have this vaginal delivery. And at some point, the scar in that uterus can rupture. The uterus can rupture,
Correct.
and now the baby is at risk.
Correct.
Not getting oxygen now.
And the mother.
And the mother is at risk as well.
Correct.
So baby and mother are at risk. So who's at the biggest risk in that situation?
Well, the baby is pretty vulnerable to loss of oxygen during that time.
Okay.
So the mother's risk is bleeding, infection, and unfortunately, very rarely, hysterectomy, which might terminate her childbearing choices going forward or alter her childbearing pattern going forward. But those are the biggest risks.
Okay, those are the biggest risks. And when we're talking about the mother, there's the bleeding, the infection, loss, requirement of a hysterectomy, and for the baby, the lack of perfusion of oxygen to the brain is what we worry about mostly in that period of time after the uterus ruptures, before the baby is born.
Right. So a large number of those babies do fine. A small number of those babies can either die, unfortunately, or suffer severely from lack of oxygen.
Okay.
Okay, so when someone's coming into the office to talk about this, you obviously discuss these risks. Are there specific risk factors from someone that's had a previous C-section? You say, this is what makes you not a very good candidate for a trial.
Absolutely, yeah, great question. So there are some people that it's a contraindication.
Okay.
So if their incision in their uterus is not sideways, so it's up and down.
Right.
So the patch on the uterus is not in the most ideal way if we use the wheel analogy. Okay. So if it's up and down, that's an absolute contraindication.
Because the lines, because it is perpendicular to the tension in the uterus.
Correct.
And
So we
that's
know
what's
that the
interfering.
muscles
Right.
can separate
Right.
more that way. That's
Yeah.
called the classical C-section.
Right.
If they've had more than three cesarean sections, that's an absolute contraindication.
Yeah, that's a lot of babies.
Yeah, that's a lot of babies. So if you've had 3 cesarean sections, it's an absolute contraindication. If the placenta is covering the cervix, that's an absolute. So there's those maternal and fetal risks as well, which can sometimes lend you to be, and your provider will go over all of those with you. Those are pretty rare, thankfully. TOLACs are successful 75% of the time. For the general population. And if you've been successful once before, so if you've had a vaginal birth, then a cesarean section, your success rate can be anywhere up to 85% of having.
Wait, vag first, then cesarean, then vag again?
Correct.
Wow.
So if you have a proven pelvis and you've delivered once vaginally before, your chances of being successful are pretty high, about 85%.
Did you say proven pelvis? You mean essentially a pelvis that can deliver a baby?
Correct.
Proven
So
pelvis.
it's not for what we call dystocia, or there's a smaller pelvis, so the key doesn't fit in the lock for whatever reason.
Got it.
So with these risks of a cesarean section, of a vaginal delivery after a previous cesarean section, you talked about some big risks to the mom, to the baby. Why are some people still choosing to go that route?
Because outcomes from mothers can be better, for sure, and outcomes for babies can be better. Cesarean sections are complicated. They have increased risk of bleeding, blood transfusion. There still can be injury to the baby. Subsequent pregnancies can be complicated, especially in the patient who wants 2 or 3 children.
Okay, so on the balance of probabilities, which one is safer? The C-section after the C-section or the vag birth after the C-section?
So safety is a personal choice. So every single person will assume risk and safety based on, after a consultation. There are some things called vaginal birth predictors after cesarean section. There are algorithms and programs where you can input data like your age, your stature, your weight. For example, we know you'll be less successful if your weight is over, or if your BMI is over 30. If your BMI is over 40, that drops even further. If you have short stature, if the interval of delivery between the birthdays are less than 18 months, you have an increased risk of uterine rupture.
So it hasn't healed yet, essentially.
Yeah.
Take a couple of years for those scars
Exactly.
to heal.
So there are calculators if you've had other comorbidities like diabetes, a big baby greater than 4 kilos, so that's almost 9 pounds for our. Or if you've had 2 previous cesarean sections, that increases your risk of rupture and decreases your risk of success.
Okay.
What do you do? What's your counseling? Like if someone comes in, they've had a cesarean section, they're here for their next one, do you sort of start going down the cesarean section discussion, or do you just leave it wide open at the beginning, or do you lean towards the vag birth?
I support both choices, and at the end, for my patients when they come for their postpartum visit, I think that's a good time to say, listen, you qualify for a vaginal birth, you don't qualify for a vaginal birth. If you really want a vaginal birth with your next pregnancy, wait 18 months for the interval. There's a lot of information about counseling the patient at that time. As to
early
what
planning,
happened.
right? Yeah,
Debrief.
sure.
Debrief. And if the patient really wants a vaginal birth, you have to, if they get pregnant within 12 months, we can't recommend a vaginal birth
Gotcha.
safely. We can, but it increases that rupture rate to 1 in 1,000 to 2 in 1,000 as opposed to.
Doubles it. So relative risk of
Correct. Yeah.
2.
20 in 1,000, sorry, not 2. From 5 to 7. Yeah.
So it does increase the risk.
Yeah.
So that's another long discussion you're
That's
having.
another long discussion. Yeah, it's a long concept.
And I think it highlights kind of the thing about some people, I think, take for granted that it's easy to get pregnant, that it's easy to have a pregnancy, and that it's easy to have a baby, and that it all is just fine, which most often it obviously is. But I think there are some very real, measurable risks that you have to be aware of and have to have long, thoughtful conversations with your partner as well as with your doctor about what's best for you and for the baby.
Yeah, for sure.
Yeah. Wow. Now you know. Leave a comment, please, if you've had a TOLAC, or maybe back in the day, maybe you actually had a VBAC. Leave a comment. It's just going to help other people. If you like this video, please like and subscribe to our channel.
And remember, you are in charge of your own health.
And thanks to Dr. Andrew Getty for enlightening us on this really interesting topic.
Thanks for having me.
We'll see you next time.